I think this is a really pivotal time in medicine. When you and I trained decades ago, we had to have knowledge in our head because that was where the information needed to be. And with the advent of first computers and now smartphones, the emphasis has been more on clinical reasoning than on factual recall. AI is going to present the kind of impetus for change that computers did, because now part of that reasoning can be outsourced to AI. But it raises some fundamental questions around what does a physician have to know in this new era? And I think this is all just in its infancy, and I look forward to seeing how it's going to unfold.
Welcome to the Physician's Pulse, where we have meaningful conversations about the future of medicine, physician well-being, medical education, and healthcare leadership. I'm your host, Dr. Ramin Manshadi. Today, I'm honored to welcome Dr. Suzanne Murin, Dean of the UC Davis School of Medicine, a nationally ranked medical school that she has led since November 2021. Dr. Murin has been part of the UC Davis for more than 30 years and has held several major leadership roles within the School of Medicine and UC Davis Health, including Vice Dean for Clinical Affairs and Executive Director of the UC Davis Medical Group. She is also a professor and practicing physician in pulmonary critical care and sleep medicine. Before joining UC Davis, she served as a U.S. Air Force Medical Corps officer. Today, we'll discuss the evolving landscape of medical education, physician wellness, healthcare leadership, and how we can build a more sustainable future in medicine. Dr. Murin, thank you so much for joining us today.
It's my pleasure, Ramin.
Before we get started, can you please give us a little background for our audience and share the mission and vision of UC Davis School of Medicine?
Sure. So the mission of the UC Davis School of Medicine is as follows: transforming lives by improving health through the combined power of education, research, clinical care, and community. We have a dedication to improving the health of society through research and education, and to empowering our community to serve with kindness and transparency to improve the health of everyone. At the end of the day, I would say that we very much see our purpose as preparing the healthcare workforce that the state of California needs.
I, too, have been involved with UC Davis Medical Center for the past 40 years. Started as a volunteer when I was 18 years old. So I do agree that it truly serves the community well. So as you know, this podcast is about physician well-being and physician burnout. And from your perspective as a dean, what are the key aspects of medical education and training today that may be contributing to burnout among students, residents, and early career physicians?
I think that there is a perception that it has become more competitive to be admitted to medical school, obviously the first step on the pathway to being a physician. In the end, that's actually not true. The AAMC recently reported that the overall acceptance rate of those people who wish to go to medical school and apply, the overall acceptance rate has been about 40% for several decades, and that really hasn't changed. What has changed is the acceptance rates of individual medical schools, because students now apply to far more schools than they did. So the acceptance rate at any given medical school is quite low, given the volume of applicants. So for example, at UC Davis School of Medicine, we accept about 3% of the students who apply to attend. But ultimately, about 40% of those who aspire to be physicians will be admitted to a U.S. medical school at some point, though some of them apply obviously more than once in order to do so. So this phenomenon of which we see even at the college level, of students applying to more schools than they ever did before, really, I think, because of that large volume of applicants to any given school, that it has almost a feel of randomness to it, to students. And it becomes a self-propagating phenomenon where, with those low acceptance rates at any given school, students feel compelled to apply to more and more schools. And it really, amps up, I think, the pressure on them. And I don't really see a way around that. They've tried to address that in the residency process through initiatives around signaling so that students can signal their strongest interest in a smaller number of programs and get rid of that sort of random lottery-like feeling. But nothing like that currently exists at the time of application to medical school. So I know that it is very stressful for students. And I don't see a way around that except for preparedness and commitment.
When we applied to medical school, I don't know, 35 years ago, something like that, we just wanted to finish college and get there as fast as we can. But I've been hearing from many students, because as you know, I teach medical students and fellows and all that, everyone is taking gap years. What is this gap year business? And 1 year gap year, 2 years gap year, is this student driven or is it something that the medical schools are looking for?
No, I think it is more student driven. Students want to be competitive. They want to get accepted. And many students are choosing to use a year or more of additional time between college and medical school in order to enhance their preparedness. That may be through doing clinical work of one sort or another, whether on a volunteered or paid basis, or by doing research, again, to strengthen their application. So it is very much student driven. I think there are some students as well who recognize that the pathway to becoming a physician is a pretty arduous one. And once they start down that path, they are in for a decade or more of intense, study and training. So they often choose to take that time, I think, just for themselves to feel prepared for that gauntlet that lies ahead of them.
All right. So if you have a student that is very competitive, has done all the extracurricular work and has done some impactful work while they were a student versus someone that had a little bit less but took a year and did more research, would you look at them the same, or what are your thoughts about that?
Well, we do use a holistic approach to admissions. So we really try to look very broadly at the candidate, their academic preparedness, their life experiences, what they've overcome, the resilience they've been able to demonstrate. So again, if a student is able to field a competitive application straight out of college, I would certainly encourage them to apply. I think you're aware the average medical student now at the time of entry is 24, which is a little bit higher than it was a few decades ago. So it's not that students are taking long swaths of time before applying. That just really reflects a year or two on average of extra time that students take. And remember, that's made up not just of students who chose to take a year knowing all along that they wish to go to medical school, but also students who decide later in life that they wish to become a physician. I mean, we see students who have had other careers even before, feeling called to medicine. So that age of 24, I think, reflects both of those phenomena.
So what advice would you offer to pre-medical students and medical trainees on building a career that is both meaningful and sustainable over long term?
I guess the first thing I would say is pick a role within medicine, a specialty or a type of practice that you find particularly rewarding. There's that whole expression that says, love what you do and love your work and you'll never work a day in your life, sort of thing. And I think that's really important to pick something that you think you will enjoy over a career that's likely to span decades. And you're certainly well aware, Dr. Manshadi, how much difference there is between different specialties of medicine, ranging from, fields like pathology, where you may have no direct patient interaction, to being a family medicine physician, where you will interact with patients and their families over years or even generations. So I think you have to figure out what speaks to you about medicine, right? To what extent it's the intellectual appeal of the field, because it is a really, really intellectually satisfying career, versus the patient touch part of it. And find what best aligns with what has drawn you to medicine so that you can go to work energized every day to do something that you want to do. Then I would say search for a practice setting that best resonates with you. As I think you're probably aware, but our audience may not be, there's been a real frame shift in medicine over the last 10 to 15 years, with a very large proportion of physicians leaving private practice where they were self-employed and had a great deal of autonomy and control to being employed by various entities, whether it's a health system, some cases now a venture capital-backed firm, or just a large multi-specialty group. And we know that autonomy is a major determinant of career satisfaction. So I would urge, again, physicians to think about what's important to them and to seek a practice setting that best resonates with that in order to have that sense of fulfillment.
Yeah, that is a very powerful insight. I'm in private practice, but I also added, all the stuff that I do on the side with volunteer faculty at UC Davis, so that I'm in touch with future generation of physicians, and more graduates are trying to find a easier lifestyle by going to the bigger organization, larger organizations. But autonomy is extremely important. But at the same time, we add another layer of stress because I'm running a business on top of being in private practice as a physician. So it's been difficult, but you're right. We all have to work together so that all modes of practices are sustainable, and find a way to deliver the best possible care for our patients.
I will put in a plug for academic practice, which I've been fortunate to be in throughout my career, because that combination of clinical practice with teaching the next generation, with doing research to discover new knowledge and new ways of practicing, that variety, I think, adds another level of satisfaction compared to a career that might just be exclusively clinical practice. And for me, that has kept things, fresh and interesting and engaging, and has kept me, very fulfilled and burnout free through now 40 years of practice.
Oh, wonderful. So medical schools play a critical role in shaping the culture of medicine. What initiatives or changes do you believe academic institutions, particularly at UC Davis School of Medicine, can implement to help better support physician well-being?
I guess first I will say that there's no question but that it's a challenging pathway. And we are a bit limited in what we can do, right? There is no part-time pathway or executive pathway through medical school. And that lack of flexibility is a nationwide phenomenon, and I think does make things challenging for people that have more complex lives. But what we do is try to support our students and our community in a variety of ways. So, for example, we have an academic and staff assistance program, which offers free confidential counseling services to faculty, staff, partners, spouses, etc. We have a Support You peer responder program, which is a confidential program that provides peer support for those who are experiencing stress or have had adverse experiences in the clinical arena. We have clinician health and well-being wellness grants available so that folks in our community can create health and well-being initiatives in their individual units or departments. And then we offer a variety of support groups and wellness programming. We also offer affinity groups so that people can create a sense of community with others with shared backgrounds or interests. So there are lots of things that we try to do to support people bringing their full selves to work and feeling supported through these stressful times.
Do these students really take advantage of all the resources that you have provided? Has it been effective?
I think in general, it has. For example, we have psychologists on staff and offer free counseling and support to our students, and those services are well subscribed. I think for many, many years there was a stigma in medicine against seeking out mental health support, and that was reinforced by a variety of things, including the need to report to licensing bodies whether you had ever sought mental health care. And that stigmatization is going away, right? That need to report on your seeking mental health care is diminishing across state licensing boards. And we very much encourage people to get the help they need. It is not a badge of honor to proceed without assistance. We encourage people to do this. And I will point out, this is independent of our school, but something really valuable in our region. And that is that our local medical society, the SSVMS, offers free mental health counseling to physicians in our region. They will refer you to a mental health practitioner anonymously and provide that support for free. And so I think destigmatizing the need for support in these challenging spaces that we live and work in is absolutely crucial. And I'm very happy to see that happening.
That's wonderful. Has the curriculum changed over the years at UC Davis? I know when I attended medical school, not at Davis, but in Chicago, the first 2 years were dedicated to only classwork. And then the next 2 years, third year was very rigorous. Has School of Medicine at UC Davis changed this curriculum to help students?
We have. We instituted a new curriculum about 5 years ago that we started, and it's now fully implemented. And I would say the main changes in that curriculum include earlier exposure to the clinical setting. Students now spend some time in clinical settings right from the beginning of medical school, and there is more of an effort to integrate the basic sciences and the clinical so that students understand the relevance of the basic sciences to the clinical care they will ultimately provide. So that higher degree of integration and greater clinical exposure early on are the key changes. The third year is still the third year, where it's a very intense and rigorous clinical experience. That hasn't changed. One other thing that has changed, nationwide, right? This is not just a UC Davis thing. This is coming from our accrediting bodies and what they like to see, but is more self-directed learning by students, sort of flipped classroom models, more self-directed learning, less time spent sitting in lecture halls, and more time learning on their own, and then spending that time that they have with faculty just with clarifying questions and things like that. And I think that in large part really reflects the fact that we are in a profession where lifelong learning is absolutely essential, right? The rate of change in medical knowledge or the rate of emergence of new knowledge is faster than ever, right? So much of what is pertinent to practice nowadays we didn't learn when we were in school. So every physician really needs to be a lifelong learner to keep up with the field and to be able to give patients the caliber of care that they deserve. And so we really do try to inculcate that very early on because it's essential.
What do you think of the advancement of all this technology now with artificial intelligence? For example, myself, I will keep telling my children, I wish I had ChatGPT when I was younger. I don't have to go to library, pull a book, try to find things. And now we have open evidence, as you know, that really helps with getting knowledge that can help our patients. So what are your thoughts about this whole AI and the curriculum at UC Davis School of Medicine?
Yeah, so we don't have the answers yet, right? We have a task force right now that is working on our AI policy and sorting through what our expectations are of students, of how they will be encouraged to use AI as part of their learning journey. But I think this is a really pivotal time in medicine. When you and I trained decades ago, we had to have knowledge in our head, because
That's right.
there was no computer you could go to and look something up. I know I'm dating us, but it's true. It used to take several days to get a literature search done with the assistance of a librarian. You could not just go look
That's
things
right.
up. All you had was what was in your head and what might be found in a textbook that you might access in a small library within the hospital. So we really had an emphasis on committing knowledge to memory, because that was where the information needed to be of use to you. And with the, advent of first computers and now smartphones, factual recall is less important. And the emphasis has been more on clinical reasoning than on factual recall. And I think AI is going to present the kind of impetus for change that computers did early on, because now part of that reasoning can be outsourced to AI, right? So the clinical reasoning that's so crucial to what we do, we now have assistance with that. It's also going to change how we interact with patients, because patients are going to be coming into the office having done their homework, having used AI themselves in an attempt to decide on a diagnosis or a management plan. So we'll be interacting with patients in different ways. And I think this is all just in its infancy, and I look forward to seeing how it's going to unfold. But it raises some fundamental questions around, what does a physician have to know in this new era? I think that's going to be defined probably more at the level of accrediting bodies than at the level of individual schools, right? Because students still have to take examinations right now that assess their knowledge and reasoning. And I think it's really an evolving thing. I don't know the answer.
I do recall when I was a resident intern, we used to call our Scott Monkey book on this in our pocket, lab coat pocket, as our peripheral brain, as you recall.
Yes.
Running around now, people have probably phones and open evidence and so forth. Going back to your own background and your history as a medical student, trainee, physician leader, can you share with our audience, actually, any time in your life that you had a difficulty that you have to overcome with patient care or in general in leadership that you can share with us and with our audience?
Well, I've been very, very fortunate in having a career that I have found, very rewarding, and I've never wavered from my commitment to medicine. But there was a point earlier in my career when I was just horribly overextended. I was a mother of 3 young children, and I so loved what I did that I just said yes to everything I was asked to do, and found myself just overwhelmed and couldn't see a way out of that, because I loved each of the things I was doing. So it was hard to imagine, giving up on any of them. And ultimately, I left academic medicine and the clinical practice of medicine for a year, and went to work for Genentech, a biotech company, for a year. It allowed me to work from home and to have a much slower pace for a year, but it also allowed me to reflect on what was really important to me. And I was very gratified to return to UC Davis after that year. I think having learned some things that have served me well in my career after working at a very high-performing company. But that time away really allowed me to reflect on what was important to me, and then to go back with, sort of renewed energy and with the insight to know that I had to pick and choose a little bit and couldn't do everything and do it well without, sacrificing too much of myself.
And I think this perspective that you shared can help our future generation of female or women physicians, because we know now 55% of medical school students are females, right?
It's a little more than 50% women now. I'm proud as a woman to say there's a body of evidence that actually shows better patient outcomes when they're cared for by women physicians, and higher satisfaction when they're cared for by women physicians. And that's all great. In part, though, that comes at personal sacrifice for women. We tend to spend more time with our patients, for example. So I think we give a lot to our jobs, and therefore do risk burnout in so doing. But I think that, we talk about having it all, and most people would say you can have it all, just not all at once. And it's important to try to balance these things across different life phases. Probably the best piece of advice I could give to young physicians, whether male or female, is to outsource everything you can that you don't find particularly fulfilling, right? Do not clean your own house. Do not do your own errands. Anything that is not personally rewarding to you that you can pay someone else to do, you should, so that your time is available to you to be the best professional you can be, and then to find your personal life as fulfilling as it can be. So you really just need to put your resources to work to free you up to do the things you most enjoy.
Dr. Susan Murin, thank you again for sharing your wisdom and leadership with us on the Physician's Pulse. And this will really, truly help the future generation of physicians. Thank you again.
Thank you, Ramin.